there's someone who has torn it apart, and she's taken just all that I have. If you wanna try to love again, well baby, I'll try to love again, but I know the first cut is the deepest.
Good morning, everyone. Good morning. Thank you for coming to the Kerrville VA Wound Seminar today. If you haven't already signed up, please sign up in the back. Okay. You should have an evaluation form in front of you, and if you don't, just raise your hand and we'll give one to you. There's coffee, there's tacos in the back, and water. We also have soda, which we ask for a 50-cent donation if you want canned soda. The restrooms are in the back of us, behind the double doors on the right-hand side. We ask that you turn off your pager or your cell phone as a courtesy for others. Let's see. Your evaluation needs to be turned at the conclusion of the program, and we'll give you your certificate of completion. You have to attend the full entire program in order to get the certificate. There should be a disclosure information on your table that looks like this. And there's no conflicts of interest noted with the program's guest speakers. Sponsorship for this program is provided by the VA here and also UT Health Science Center, and there is non-endorsement of products and no off-label uses mentioned in this program. And that addresses the questions on your evaluation. Lunch will be provided this afternoon. And we'd like to thank you, our sponsors, for providing our meal. And they include Kinetic Concepts, Hollister Wound Care, Health Point, Shire, Regenerative Medicine, EO2 Concepts, Organogenesis, and High-Tech Rehab. I'd like to begin with introducing our first speaker. Dr. Dianne Rudolph is a nurse practitioner who currently works here in Kerrville in Havens Hero. She has her doctorate in nursing and is board certified. She has experience in wound care since 1996 and is a certified wound care and ostomy nurse. She has taught at UT Health Science Center School of Nursing in San Antonio and is a much sought after speaker. She was our wound care nurse actually over at Audi prior to coming to Kerrville VA. She is frequently sought by her colleagues for expert consultation on wound care issues. She has been a great asset here and an incredible resource since working here for all of us. Please help me welcome Dianne.
How's that? Can you all hear me okay? Yes. All right. If I'll just try to project, and if it sounds like my voice is fading, just kind of throw something at me from the back, hopefully nothing that's too wet or messy. And we'll go from there. Well, now that we have you awake and we've cleaned out your eardrums, hopefully you'll be in good shape for the morning. We thought it would probably be really helpful to start off by talking about kind of a wound care 101, if you will. So for some of you who are already doing a lot of wound care, this may be a little bit of a review, but hopefully it'll also kind of give you a good foundation for the rest of today and for tomorrow as well. So with that in mind, basically we're going to talk a little bit about how you classify wounds. I think one of the big things out there is you hear people talk about wounds in a lot of different parameters. So we're going to talk about some classification schemes. A little bit about what a full thickness versus partial thickness wound is. We're going to talk about some of the parameters that you would look at as part of a comprehensive wound assessment. Again, one of the things that's so really critical when you're looking at a wound is really being able to systematically look at it. And you know, I know so many times, especially when you first start looking at wounds, there's a real tendency to open up that dressing and go, oh God, and just kind of not want to deal with it. And you know, you see necrotic tissue, some providers, some clinicians will see necrotic tissue and they'll go, oh, it's infected. Well, it may or may not be. So again, those are some of the things we're going to talk about here. I want to talk about the phases of wound healing. Again, it's kind of one of those painful pathophys 101 things, but it is really important because if you know what phase the wound is in, it really kind of helps you as part of your assessment. It helps you to determine, you know, if a wound is healing well, if it's in that proliferative phase of healing, or if it's stuck in the inflammatory phase. That's really helpful to know as well. We're going to talk about infection and colonization because that's a really big topic in wound care. and just some basic principles of wound management. And so hopefully this will kind of set the foundation for the rest of the day. So before I get started with that, I really want to emphasize the fact that a lot of what we're talking about today is really going to be discussion on what we call chronic wounds. You'll hear about acute wounds and you'll hear about chronic wounds. And it's important, I think, to understand that the main difference between them is that an acute wound is a wound that is typically something you see in a really healthy host. That could be somebody who is basically very healthy. They go in for a routine appendectomy. They have a surgical wound. Heals beautifully, no problems. That's an acute wound. You're doing a little bit of work in the kitchen and you go reach into the oven and you grab something out of the oven and it's a little bit hot and you don't have a good set of mitts because you were in a hurry and you burn yourself. You take good care of that particular wound. It heals up pretty well, no problems. Again, that's an acute wound. Those kind of wounds we don't really get as excited about because generally acute wounds occur in healthy hosts and they generally will proceed along a normal continuum of wound healing. And you know, if you have somebody who's healthy enough, you can take an acute wound and put cow manure in it and it will probably still heal. So those kind of wounds we don't get that excited about. What our focus is are on the chronic wounds. And a lot of what we're going to be discussing will be primarily chronic wounds. So what is a chronic wound? Probably the best way to think about a chronic wound is that it is a wound that, for whatever reason, has gotten stuck in that normal wound healing process. And again, we're going to talk about the phases of wound healing, but a chronic wound is usually stuck somewhere in one of those phases of wound healing. So again, as part of your assessment, if you can look and go, gosh, this wound just seems like it's chronically inflamed, that'll kind of help you with formulating a plan of care for taking care of that wound. So the other way to think about chronic wounds too is that a chronic wound is often a symptom of an underlying problem. And as we go through that, that'll make more sense. But if you think about it, pressure ulcers are a very common type of chronic wound. And a pressure ulcer is really a symptom of an underlying problem, i.e. immobility or lack of sensation. Cherie's going to be giving you a talk a little bit later about pressure ulcers, and she'll be talking a little bit more in detail about that. But just to kind of frame things for you, acute wounds, again, they heal in a normal pathway, usually not too problematic. Sometimes they'll heal no matter what you do or don't do to them if the host is healthy. But a chronic wound you see in more of an unhealthy host. These are patients that have lots of medical issues, and the wound is usually a symptom of an underlying problem. Pressure ulcers we talked about, vascular ulcers are usually a perfusion issue, and some of the other types of wounds that we'll talk about. So I just kind of wanted to set the groundwork for that, and just kind of keep that in mind as we move along. So when we talk about wounds, one way to look at wounds is the depth of a wound. We can look at wounds in a number of different ways, but if you think about it, we have kind of a continuum from intact skin all the way to full thickness. So your intact skin, basically when you think about the stage 1 pressure ulcers, the skin is basically still intact, but you've got a little bit of initial damage. That's kind of what we're looking at when we see this, when we see intact skin. Superficial is, again, just that minor little excoriation, that little tiny abrasion, something that's very shallow, very superficial, usually not anything that's too exciting. Partial thickness is where now we have an opening in the skin. We've penetrated the epidermis, and now we're into, just that top layer of skin being gone. And, certainly with proper care, those generally will heal up pretty well, and they don't usually represent too much of a problem. The full thickness wounds are the wounds where now you've gone all the way through the epidermal and dermal layers, and in this case, sometimes you're into subcutaneous tissue, sometimes even into muscle, bones, or even joint cavities. So as you can appreciate, those can be a lot more serious to deal with. So just a little bit about Patho 101, because if we're going to be talking about the foundations, we got to give you a little bit of that patho. When we talk about the skin, again, when we talk about partial thickness damage, we talk about damage that really only involves the epidermis. When we talk about full thickness damage, we talk about damage that has now penetrated the epidermis, and now you're into the subcutaneous tissue. Now you're into the dermis, and then into what we call the hypodermis, or the subcutaneous tissue. So as you can appreciate, the deeper we go, the more challenging it can be to get that wound to heal in a normal fashion. Again, your partial thickness wounds generally will heal up fairly appropriately, fairly quickly with proper care. Most of your partial thickness wounds will heal usually within about 2, maybe 3 weeks tops. Whereas your full thickness wounds, you know, now we're getting into some of the active structures in the dermis. Those are going to definitely take a lot longer to heal. Here's a couple of examples again to show you. Partial thickness, this is basically, you can see where there's not really any depth of the wound. That top layer of skin is gone. There's no real measurable depth, and you don't see necrotic tissue in partial thickness wounds. Very important clinical pearl. You never see necrotic tissue in a partial thickness wound. Again, no real measurable depth, and what we can see here is just that top layer of epidermis is gone, and we're just seeing some of the exposed dermis. Those are partial thickness wounds. They're very shallow, no appreciable depth, no necrotic tissue, and if you can initiate a good plan of care, you can pretty much heal these up a little bit more quickly than your full thickness wounds. And your full thickness wounds, as you can appreciate, these definitely involve a lot more tissue damage. These are usually a lot more extensive. Now we've gone all the way through the epidermis and dermis, and we're into subcutaneous tissues and beyond. So when you have that kind of damage, you also have a lot of tissue loss as well. So as you can appreciate, it's going to take a lot more energy on the part of the body, a lot more reserves to try to create that new tissue to fill in these wounds. This, just by way of example, is, this was an older lady who was on dialysis, and she ended up having a paniculectomy. This is, her head would be up here, feet down here. That's just a little drainage tube. She had a paniculectomy. And she also developed calciphylaxis, which is an abnormal, it's an abnormal metabolic process where you get deposition of calcium in the tissues, and it causes occlusion of the little tiny capillaries, and it causes these horrible, it's usually not a very good prognostic sign, but you can see that this is a very, involved full thickness wound. This is a patient who has a full thickness pressure ulcer of the sacrum. His head would be up here, feet down here. And you can actually see that, we've gone all the way through all the layers of tissue, and we now have some exposed bone. That's part of his sacral bone back here that's peeking out at you. So that's one way to look at wounds. Another way that we can look at wounds, and I'm going to kind of go through this a little bit quickly because Cherie will be talking a little bit more about this, is by what we call the pressure ulcer staging system. Now, very, very important to keep in mind when we talk about staging an ulcer, usually we talk about stage 1 through stage 4. Stage 1 usually represents the least amount of damage, stage 4 the greatest amount of damage. And what's extremely important is we only stage pressure ulcers. I've seen clinicians, very well intended, they'll go in and stage diabetic ulcers and surgical wounds and, burns, and we really don't want to do that. Staging really is only applicable for pressure ulcers. So when we talk about staging, again, we're talking about the layer of anatomical damage. So just very briefly, I'm going to run through this, and you will get, this is a preview of coming attractions. Stage 1 is non-blanchable erythema of intact skin. So this is the patient, you go, you move them, you see this red area, you depress it with your thumb, it doesn't blanch. You all know what I mean when we talk about blanching? Okay. And it doesn't go away. And the epidermis is still intact, but you've got this sort of permanent discoloration that's not going away. That's your stage 1. The thing that's very important is if you have a patient who's a little bit darker complected, darker skin tones, this may not be as obvious, so you also want to palpate. So if there's warmth, tenderness, induration, or firmness, that's also kind of suspect for possible stage 1 ulcer. Stage 2, this is considered a partial thickness ulcer still. So we've broken the top layer of skin is gone, the epidermis is gone, and we have some exposed dermis, but there's no real depth to the wound. Again, very partial thickness, very shallow, no measurable depth. Now stage 3 for pressure ulcers, full thickness. We've gone all the way through the epidermis, and now we're into the dermis, and we've got exposed subcutaneous tissue. And this is where a lot of times you'll start to see a little bit of that non-viable tissue. Now, there's always that idea of if there's necrotic tissue in the wound, you can't stage it. And Cherie will clarify this later for you, but just, You can still stage a wound if there's necrotic tissue in it, as long as you can visualize the base of the wound. So in this case, we've got a full thickness stage 3 pressure ulcer. You can see we've got some granulation tissue as well as some slough in that wound. And here as well, you can see it's a full thickness wound. We've gone all the way through the epidermis and dermis. We're into subcutaneous tissue. There's a little bit of fibrotic debris there at the edge. And if you were to take a sterile Q-tip, you could run your Q-tip under that rim and find that there's actually a little shelf or a little dead space there as well. So that's a stage 3. And then, of course, stage 4 represents the greatest amount of tissue damage. That's where we've gone all the way through the epidermis, dermis, we're into subcutaneous tissues and beyond. And as you can see, this is a patient, this was an older lady, 90-something, with full thickness stage 4 pressure ulcer. It actually ended up healing quite nicely. But you can see that there's a lot of scarring, and you can see that there's an open full thickness wound, and there's a little bit of tunneling and undermining that you can't really see. These two wounds are connected. And this was an elderly gentleman who was APS case, not a VA patient, who ended up with these large bilateral ulcers on his hips about the size of dinner plates that were debrided, and you can see that we have exposed muscle, bone, tendon. You know, very, very dramatic, of course, when you see those kinds of things. Those are kind of obvious when you see a stage 4 like that. There's also the concept of deep tissue injury. How many of you have heard of deep tissue injury? Okay, so some of you have some familiarity with that. That is another one of the different stages. Again, we're talking about pressure ulcers only for the staging system. But the deep tissue injury was first identified in 2007 by the National Pressure Ulcer Advisory Panel. And what that is describing are those kind of wounds that you look at the patient and you see kind of like this dark purple maroonish. It's not really a stage 1, but it's not really eschar, so it's kind of like, well, where does this really fall? And that's your deep tissue. It's a non-blanchable area of usually maroon or ischemic looking tissue. This is just a really good example. You can see that there is this very dark ischemic looking tissue. The unfortunate thing about deep tissue injuries is that when you see these, they frequently are a sign of some underlying damage that's continuing to evolve. So a lot of times these get worse before they get better, and it's not uncommon for these to develop into eschar.
So how do you treat these?
Well, with the deep tissue injury, the biggest thing with pressure ulcers in general is prevention is absolutely critical. Cherie will be talking about that, getting them offloaded, getting them on an appropriate support surface, getting them on a turning regimen, looking at their nutrition. And then topical management for something like this would usually be, if the skin is still intact, usually you could put a protective dressing like an Aleve on there, or you could use a barrier ointment just to help decrease friction and shear on that site. But very good question, and I know Cherie will talk about this a little bit later in a little more detail, but that is a great question. But prevention is probably the key, but unfortunately by the time we get these, a lot of times we have already gotten them. We've already been gifted them, so we have to figure out what to do with them. This is another example of a deep tissue injury. Deep tissue injury is where you have a blood-filled blister. Serosanguinous-filled blister is another form of a deep tissue injury. So these are kind of two different variations of the same type of a wound. Does that make sense so far? Okay, very good. So the limitations of staging, you know, a lot of times you can see something that may not look that exciting at the surface, and 3 days later, you've got a full thickness ulcer. How many of you have seen that, where you kind of have like a kind of a dark discolored area on a Monday, and you know, several days later, you've now got a full thickness wound, or you've got eschar. So it is not unusual to have a wound that can progress fast, especially if you have a very sick host, if they're malnourished, if they're septic, if they are immobile, or if they have a lot of other comorbid conditions. As I mentioned, if the wound base is not visible, if you cannot see where you are anatomically, if it's covered with eschar or covered with slough or non-viable tissue, you cannot stage the wound. And it's completely appropriate to document that as an unstageable pressure ulcer, completely appropriate. And you never want to reverse stage a wound. You know, you can be doing some of the best care in the world. You can be taking care of this wonderful, well, they're never wonderful, but you can be taking wonderful care of a stage 3 pressure ulcer, doing great things with it, and it's improving. It's developing granulation tissue, it's filling in, it's doing beautifully, and it's really become very, very shallow. Well, it may look to you like a stage 2 ulcer, but you never want to, go from calling it a stage 3 to a stage 2 ulcer. You never want to reverse stage, because basically you're denying that depth of anatomical damage that's occurred. In that case, you really would want to call it a stage 3 healing pressure ulcer. Does that make sense? Okay. And again, if you have questions as we go along, feel free to make comments or ask a question. It just makes it a lot more interesting than me just listening to myself. And I know then that you're listening and not falling asleep. I'll be watching you for the O signs and the Q signs. You know what those are, right? The O sign is when you start to relax, especially after you've had a nice breakfast taco and you've had your coffee or your drink, and your neck muscles start to relax and your eyes start to kind of relax a little bit, and you kind of go down to half mast, and then the head tips back and the mouth drops open. That's the O sign. And then the other thing, of course, is Q sign. That's when your tongue starts hanging out. So you have to kind of, if you see your neighbor doing that, just give him a little shove. Here's a couple of examples of the unstageable pressure ulcers. Again, we can't see exactly where we are, so we cannot stage them. So let me move into wound healing. We talked about, a little while ago, you have a wound that is, you get a little burn in the kitchen, you put a little bit of salve on it or a little bit of, TAO on it, and it heals up fine, no problems, no scarring. Basically when we talk about wounds, there's two major categories of wound healing. The first one is wound regeneration, and the second one is tissue repair. So what do we mean by that? Wound regeneration is, and this is why it's important when you're doing your wound assessment to kind of figure out if you're looking at a full thickness or partial thickness wound. Because partial thickness wounds heal by a process of tissue regeneration. So what does that mean? I talked about, you get that little superficial burn, you put some TAO on it, and it heals up and you have no scarring. That is the process of tissue regeneration. If you have a partial thickness wound, the body is capable of basically re-epithelializing, and basically goes through a process where if you have that open wound, once the body has gone through a little bit of inflammation and gotten that wound cleaned up, the wound will basically resurface. It will basically cover itself with new skin cells. We also call them keratinocytes or epithelial cells, all the same. Basically covers up that wound, and you have no scarring. And that is a wound that has healed by what we call regeneration. We're not really, those kind of wounds generally don't present as much of a problem to us. But for a lot of us, especially dealing with a lot of wound care, the big issue that we deal with is tissue repair. Wounds that heal by tissue repair, these are your full thickness wounds. These are your stage 3 and 4 pressure ulcers. These are your deep tissue injuries. These are your big vascular ulcers, your arterial ulcers, your venous ulcers, your thick traumatic wounds, your dehisced surgical incisions. Those are all wounds that heal by a process called tissue repair. So what I'd like to do is kind of take you through a little bit of that process of the phases of wound healing and kind of give you an analogy so hopefully it'll stick in your head when you're looking at these wounds. But we basically have three main categories. We have an inflammatory phase, we have a proliferative phase, and then we have what's called a maturation or remodeling phase. And the body's got to kind of move sort of systematically through all of these phases of healing in order to achieve closure of that wound, to achieve healing of that wound. So, first phase, inflammation. This is, again, with any type of wound at all, you can have some kind of an injury, and anytime you have an injury, it's going to mount a response in the body. So typically what happens is when there is any type of injury to the epidermis or dermis, the body mounts a response. And so the first thing that the body's got to do, of course, anytime you have an injury, there's usually bleeding, right? Because you've got endothelial damage. So the body's first response anytime there's an injury is, oh, we've got to, let's turn off the water, let's stop the flow, let's cease the bleeding. So the body will go through vasoconstriction. So there's an immediate vasoconstriction in the tissues around that area where the injury has occurred. And again, the idea behind that is to kind of decrease the blood flow. The whole clotting cascade becomes initiated, and it's a big wide pathway. You have an intrinsic and an extrinsic pathway. They come together in that final common pathway. And what happens in that case is you have that fibrinogen. We have all of this fibrinogen, which is It's a protein that circulates through the body. And as part of that clotting process, the fibrinogen is converted into fibrin. So you get these little layers or little strings of fibrin that will kind of lay a little mesh network in that wound. And the body catches the platelets, and it creates what's called a clot. And that's what we refer to as a fibrin clot. That's actually where wound healing is thought to begin. How many of you have heard of a product called Regranix, or have used it? Some of you have. It's been out there for quite a while. It's been out since probably the mid-late 90s. And it's probably not used as widely as it used to be, but Regranix was a platelet-derived growth factor. It was actually a wound care product that used the idea that when you have these fibrin clots, you have these platelets. As those platelets start to break down, they produce all these growth factors, and that helps to stimulate healing. And Regranix was a product that was used with that sort of principle in mind. So we've got the cessation of bleeding. So we've controlled bleeding, we have hemostasis achieved. So now the next thing we've got to do is we've got to clean up this mess that we have. And so the body goes through what's called an inflammatory process. There are all of these vasoactive substances. Histamines, you've heard of those when people have massive allergic reactions, there's a big histamine release. Bradykinins, prostaglandins, leukotrienes, sounds really exciting. But basically there are all these vasoactive substances, and their purpose in life is to now cause vasodilatation. So it opens up all the blood vessels in that area around the injury, and it allows the body now to flood that area with all of these different cells that are responsible for wound healing. And you get all of these specialized white cells, neutrophils and macrophages, and they kind of come in, they're sort of like the housekeepers, if you will. They come in after the fact, and they start to engulf any foreign debris or bacteria in the wound, kind of like Pac-Man, kind of engulf it and ingest it and take it out of the picture. And the idea is that you're cleaning up the wound during this particular phase. So those are very, very active. And the whole idea is to remove bacteria and foreign debris. So in a normal scenario, the inflammatory phase generally will last about 48 to 72 hours. So sometimes in a chronic wound, what can happen is you can get a wound that will just sort of stay there. It gets stuck in that inflammatory phase. So now it requires some kind of process to get the wound to move forward. And that's not uncommon with a lot of chronic wounds. So we've got all of this going on. Normally it should last about 48 to 72 hours. So in this phase, we've stopped any bleeding that's occurred, and we've basically cleaned up the wound to get it ready for the next phase. One thing that's important to remember is that during the inflammatory phase, it's normal to have classic signs of infection or inflammation. So what are you all know this from 101. Classic signs of inflammation, what are they? Redness, what else? Swelling, tenderness, what else? Heat, excellent, excellent. There may even be a little bit of induration or firmness around the wound, excellent. Normal to see this within the first 2 to 3 days. However, if this wound is 2 weeks old and it's still doing this, then you have a problem. So that's your inflammatory phase. Probably a good way to think about the inflammatory phase, it's like a house on fire. You know, you've got all this damage that's occurring, and you've got all of the vasodilatation, you've got all of this inflammation occurring, you've got heat, warmth, tenderness. Not really a place you want to be, but you've got to get through this to get to the next phase. And that's proliferation. This is a really important phase of wound healing, because this is where the body is actively making all of this new tissue to fill in this open wound or this defect in the wound. And basically what happens are those white cells, the macrophages, that were kind of helpful at the end, they were helpful at the end of the inflammatory phase. They stay around. And now what they start to do is they release all these growth factors. And the growth factors are sort of like the conductor of the orchestra, if you will. And it basically causes the endothelial cells to produce new red blood vessels, which is called neoangiogenesis. And fibroblasts are specialized cells that migrate in from the peri-wound area, and they lay down collagen. So what you have is you have new red blood cells forming a network, because if you've got new tissue, you've got to have a pipeline to feed it. So you've got to make some new blood vessels to feed the tissue, and then you've got to make the tissue. So the neoangiogenesis and the collagen fibers together they combine to make up what we call granulation tissue. And I love granulation tissue. When I'm trying to heal a wound and I see lots of good granulation tissue, I absolutely love that. It's one of my favorite things to see. I like to see that nice, beefy, red, velvety tissue in that wound. Then I know that the wound is trying to heal. It is actively healing. It is actively moving forward. So it's a very, very good thing. And again, it's that beefy red. And, you know, you ever notice in nursing that we always seem to use, food to describe just about everything. Have you ever noticed that? We have beefy red granulation, and we have milky or creamy exudate, or we have a lemon-sized, or egg-sized lump on the head. I don't know, I guess it's because it's something we all can relate to, right? So this is your proliferation phase. The body's making this tissue. It's this granulation tissue is scar tissue. It's making this new tissue to try to fill in this hole in the wound. This process can take days to weeks to months to years in some situations if your patient is really impaired. So at the end of this period of time, you've got the body filling in this area. It's kind of brought that tissue up to the surface. So as we move forward, probably a way to think about proliferation is that this is the extracellular matrix. This is where we're framing the house now. We've got the collagen fibers that are our wood structure. And we've got the red blood vessels, the neoangiogenesis, that's kind of our plumbing. So we're getting the foundations of the house built back up after that initial destruction. So now we've got that wound, it's nice, it's got that nice, beautiful bed of healthy granulation that we love to see. Now the next thing that we've got to do is we've got to get new skin cells, epithelial cells, keratinocytes, they all mean the same thing, to float across that wound. And that's also, we're still in the second phase of wound healing, of proliferation, but the latter phase of this is what we call re-epithelialization. So the growth factors cause those skin cells to float across the surface of the wound. Again, another reason when we talk about principles of wound care, moist wound healing is so very important, because if that wound is nice and moist, it makes all of that cellular activity easier. It makes it easier for those skin cells to migrate across that wound. So you get re-epithelialization. Now a lot of times we go, all right, well, you know, the wound is re-epithelialized, it's closed, it's healed. But remember, this is only the second phase of wound healing, right? So we have to move into the next phase. One way to think about re-epithelialization is that you've got your house all beautifully framed, but now you need your skim coat on it, you need your siding on it. So a way to think about this is, you know, the wound is built, but you've got to cover it with a good protective siding. So that's re-epithelialization. That's the keratinocytes migrating across the wound. Final phase of wound healing is maturation or remodeling. This is a process that can occur for up to 2 years after the wound has actually closed. And this is a very dynamic process where the body is taking that new scar tissue, that newly formed wound, and it is breaking that collagen down, and it is reforming it. And the idea is to give it more tensile strength, to make it stronger, to be able to make it withstand trauma. But a very important thing to keep in mind when you have a wound that heals this way, anytime you have a wound with scarring, as you know, scar tissue does not look and it does not act like normal tissue, does it? It's a different animal. It doesn't have the same tensile strength. It's only going to be about 80% as strong as the original scar tissue. So if you think about it, you know, you have your spinal cord patient. He sits all day long, develops a nice big stage 3 ulcer. You've done a beautiful job of taking care of this wound. You've used different modalities, and you've moved this wound all the way from a full thickness wound. Now it's epithelialized. It's going through that final phase of remodeling. And you've got this nice scar tissue there. And he turns around and he goes back and sits in that chair, and he opens up that same area again. What do you think is going to be the difficulty with maintaining that wound? It's going to be a challenge, right? So you've got this scar tissue, it's broken open, and so, you know, you go through the process again, you get it to heal up again, it goes all the way through this process. Well, now that scar tissue is about 80% of 80% as good as new. So you can kind of appreciate over time that that area becomes weaker, more susceptible to damage, more difficult to actually heal. So again, prevention is so very, very important. I know I'm preaching to the choir here, but it is very critical. So that is And a way to think about remodeling is, you know, you've got everything built, looks good, but we're going to put the furniture in. That's the collagen deposition. And then over time, remember we talked about the fact that the body's going to break down the collagen and remodel it. So same thing here. You decorate your house. It looks great. It looks like 1980s. 10 years go by. I don't like it. Let's make it look like 1990. So we take everything out, get some nice new furniture, put it back in. That's what the body's doing with the scar formation, is remodeling. Does that make sense? Okay. All right. Very good. So that's kind of a way to think about it when you're looking at wounds in terms of what are the phases of wound healing. So we have basically your inflammatory phase, 48 to 72 hours, wound is cleaning itself up, controlling bleeding, getting it ready for proliferation. Proliferation is that second phase. The body's making active new tissue, new granulation tissue to fill in that hole. At the end of that phase, you get basically epithelialization. And then the third phase, that scar tissue is remodeling itself. It's breaking itself down and reinventing itself to make it better, stronger, faster. Kind of like the $6 Million Man, something like that. Okay. All right, so as I mentioned, you know, it's really important when you're doing a wound assessment to sort of have an idea of what phase of wound healing your wound is in. So when we talk about wound assessment, we really want to make sure that as we're talking about wound assessment that we have consistency in technique. And it really needs to be systematic. It really needs to be systematic, and it needs to be comprehensive. It becomes very, very important. If you're not properly assessing, it's really difficult to know where you're going. It's kind of like navigating. You have to know where you're starting from to get from point A to point B. It's very, very important. You have to be comprehensive. You have to do it also at routine intervals. You know, I think at the VA, at least I know we're pretty good about doing it on a pretty regular basis, weekly, and sometimes even more often, depending on the condition of the wound and how the wound is doing. And we have to document. Documentation is very, very important, as you well know. I know you've heard that mantra again and again. Documentation, if it's not documented, it's not done. You need to make sure you're really clear. So as far as a wound assessment model is concerned, again, these are just some of the things that you would want to think about as part of looking at a wound, again, systematically. You want to make sure that you are looking at location, size, the presence of dead space, and I'll get to that in a moment. What type of tissue do you have in the wound? Do you have viable tissue? Do you have non-viable tissue? What do the edges of the wound look like? That's very, very important too, because it helps you to determine whether or not your wound is getting stuck. Exudate. How much and what type of exudate do you have? And how does the peri-wound look? The peri-wound is very important. And do we have pain and or infection? Those are all things that you want to sort of keep in the back of your mind as you are systematically assessing that wound. So let's talk about each one briefly. Just like your realtors, location, location, location. I think I must have wanted to be like a real estate agent or something in a former life, because I seem to be relating everything to the real estate market, but it does have a lot of good analogies with wound care. Location is very important. Just as location is important in real estate, location is also important in terms of your wound assessment. That's very, very critical, especially if you have multiple wounds. You've got to really document exactly where that wound is. And that does get a little bit tricky, because sometimes when you're looking at wounds in the sacral area, it's very important to make sure you're consistent. If I'm documenting a sacral wound, and one of you is documenting a coccygeal wound, and then another one of you is documenting a left gluteal wound, we might be all talking about the same thing, but the documentation isn't going to reflect that. So it is so critical to make sure that we are consistent with description of location, especially from an anatomical viewpoint. So location, location, location. Size of the wound. We don't have to measure the wound every single time we look at it or we do a dressing change, but we should be measuring the size on a consistent basis. Ideally, weekly is a good way to go. And typically what we like to do is, when you think about size, it's very important, again, to be consistent. So when you think about size of the wound is basically oriented from head to toe. So whether the wound is a large, round, weird-looking wound like this, or it's a wound like this, you always have to measure it. Size being, length is always measured from head to toe, and width is always from side to side. Because when you think about it, when we talked about the phases of wound healing, wounds don't heal symmetrically. You could have a wound that might look oval on a Monday, and then 3 weeks later it may be perfectly round. So you always want to measure from head to toe as length and side to side as width. In some institutions, wound tracing can be done. I don't see that done a whole lot much anymore, but it is a nice way if you have a very irregular wound. You can trace the wound and make a photocopy of it, and then you can sort of see over time how that wound is progressing. Photography. Photography, I think, is kind of a debatable thing. I think that photography is extremely useful because it really does help you appreciate with some of these wounds that have been around for, days, weeks, months. Sometimes you forget where you were, and it's really nice to have a picture that really allows you to see, how well you're actually doing. Probably the most important thing when we talk about photography, however, is that it's absolutely critical, especially from a litigation perspective, to make sure that your photograph matches your verbal document or your written documentation. They have got to be completely congruent. Otherwise, that could be a big red flag. So that would probably be the main caveat that I would emphasize when we talk about wound photography. How many of you do wound photography? Okay, so some of you have. What are your thoughts about photography? You think it's good, bad, or indifferent?
I think it's good.
So it can be.
Just so I can go back, like you're talking about, I can look back in the past and see the progression of the wound. Is it getting worse? Is it still the same? Is it getting better?
Absolutely. And I think, I think sometimes we get sort of jaded over time when we've been dealing with a wound and it just doesn't look like it's doing very much. Sometimes the documentation can prove that it really is doing quite well. So thank you. Any other thoughts about that? Okay. So the depth of the wound, that is also important because most of our wounds, especially full thickness wounds, are not two-dimensional. We have length, width, and we have depth. So when we measure the depth of the wound, very easy, we usually just take a sterile Q-tip, sterile, cotton-tipped applicator, and you find the deepest area of the wound and you kind of mark that, and then you measure it. Again, most of the time when we talk about measurement, it's usually done in metric. So you'll see a lot of clinicians will use either centimeters or millimeters, and that's pretty much the accepted standard. You don't really want to use inches because it does make it a little bit difficult. If I'm documenting in inches and you're documenting in centimeters and we have, something that goes from 1 inch to 5 centimeters, well, that's a huge issue. So you want to use the metric systems to document. So length, width, depth of wound. Now, the other thing about these particular wounds is that they don't always just go down. And you've seen that as well. Sometimes they go off, they shoot out in tracks and tunnels off to the sides, correct? And I know you've probably seen that too. So you also have to make sure that you are assessing for and documenting for the presence of what we call dead space. Dead space is either tunneling or undermining. Anybody want to give a guess as to the differences between tunneling and undermining? Yes, ma'am.
Undermining is when it goes just in like a cave, and the side of the skin, and tunneling is when it actually completely goes through.
Excellent. That's a very good descriptor. Did you all hear her? So basically, tunneling is where you have the edges of the wound are not attached, and it's like a shelf or a lip underneath the wound. And that's kind of what we're looking at here. This is a patient who has, this is basically an infected trochanteric ulcer. You can see it's pretty impressive. But when you put the Q-tip in, you can see that we've got, and you can actually almost see where it's undermined from just the changes in the skin. But that is where you have a shelf underneath, and that's undermining. And tunneling, let me just go back for a second. And tunneling is, again, as she mentioned, you have a track or tunnel. You put that Q-tip into the wound, and it goes into a track or tunnel, and you can have more than one, and they can go in multiple directions. Whenever you're documenting the presence of dead space, whenever you're documenting the presence of undermining or the presence of a tunnel, the best way to do it is to use the face of a clock, again. So if we are looking at, this gentleman and say this is his head and this is his bottom, and we've got undermining, say in this particular example, the undermining goes from here to maybe about there. So we would say that that patient might have, for example, maybe 2 centimeters of undermining from 9 o'clock to 12 o'clock. So we know that it goes in about 2.5 centimeters, and it goes from about 9 o'clock to 12 o'clock. Does that make sense? So again, you want to use the face of the clock. If you have a patient who has, you know, if you have like a tunnel that goes up this way about 4 centimeters, you could say patient has a 4 centimeter tunnel at 12 o'clock. So you want to use the face. And the reason why that is so very important is that when you're doing good wound care, one of the important principles of wound care is moist wound healing. And you want your topical therapy, you want your dressings to be in contact with all surfaces of the wound, not just slapped into the exposed part you see. So when you have dead space or undermining, you typically want to pack that with some type of a moist dressing. It could be your wound vac, it could be new gauze, it could be hydrophora blue, it could be any number of products, but you want to make sure that you're documenting that because you want to make sure that you're packing those areas, that you're addressing them. And the other thing is that you might have a wound, you know, if this wound was like, say, 9 by 9 centimeters, and for months it seemed like it was 9 by 9 centimeters, but your undermining is decreasing and your tunneling is decreasing, well, you're demonstrating that the wound is healing. So another reason why it's so very important to document undermining and tunneling, absolutely. Any other thoughts or concerns or ideas about that? Okay, not all at once. Can't get a word in edgewise with this crowd. Yes, ma'am.
Document like a Pibbly the same way as dead space?
Say that again?
A Pibbly, when the skin's rolling over, would you document it the same way?
Absolutely, you sure would. Very, very good question. And we'll get to that when we talk about edges. But what she's referring to is a Pibbly, which is the rolled, when sometimes with a chronic wound, the edges will actually roll under on themselves. And the wound healing process usually stops at that point, and we have to address that. But yes, you would document that the wound has a Pibbly from, say, 6 to 12 o'clock, or a Pibbly, you know, all the way around the wound. Absolutely. The tissue type is very, very important. Again, you know, for folks that don't do a lot of wound care, they take the dressing off, they see this, and they freak out because they see necrotic tissue and they automatically think it's infected. Well, it may or may not be, but that's why your assessment needs to be so systematic. So when you're looking at tissue, you really want to look at, you know, whether you have viable tissue or non-viable tissue. So you want to document that. You want to document the type of tissue, you know, is it eschar, is it slough, is it necrotic, is it non-viable? All of those are very appropriate to use. You know, sometimes you can have a wound that has, you know, something like this where you've kind of got mixed. This one's got some mixed slough and some eschar here. If you're not exactly sure how to describe that, you could just call it necrotic or non-viable, and that's perfectly appropriate to do. So we can see that this wound is, you know, it's got 100% necrosis. We might guesstimate, and this is where when you're looking at a wound that's got, you know, some healthy tissue and some unhealthy tissue, you want to try to document the percentage if you can. And in this case, it's 100% necrotic. This might be, you know, maybe I don't know, 50% eschar and 50% slough. I wouldn't be all that excited. If you just said it was 100% necrotic, I'd be happy with that. And here we have a beautiful granulating wound, which is quite lovely. Again, this is a dehisced surgical wound that's starting to fill in quite nicely. And that's 100% granulation. If you can, quantify by using percentages. So example, you know, if the wound has 50% granulation and 50% slough, that's perfect, that's great. And the reason why that's so important is, again, it helps you determine if you're making progress with your wound care. It also helps you to determine if you're using the right appropriate therapy on that wound. If you have a wound that started out as, you know, 100% necrotic, and you're doing, you know, maybe Santal and hydrophora blue, and now it's 50% necrotic, well, the measurements may not have changed very much, but you've got improvement in the wound because the tissue type has improved. So again, very, very important, and it also allows you to confirm the fact that the treatment that you're using is probably working on that wound. So that's extremely important, is to try to document the type of tissue. And again, as I mentioned previously, or as the slide said, generally if it ain't red, it's dead. So if you're looking at something that's not, you know, that's not red in the wound, it's generally going to be non-viable. And you want to try to examine that further and see exactly what you're dealing with. The wound edges, again, good lead-in question earlier. You want to look at the edges of the wound because, again, when we talked about proliferation, remember we want the nice open wound. We want those nice cells to kind of float across that wound and close it. Well, if we have a Pibbly What's happening there is that the edges of the wound, instead of being nice and flat and even, what they've decided to do is they kind of turn up under on themselves. And when the body is in the process of going through mitosis and creating new tissue, as those cells travel across the wound, once the cells touch each other, there's something called contact inhibition, and that's the signal to the body that, oh, good, we're done, we can go home for the day, we are all closed up, not to worry. But when the wounds roll under, it's the same exact thing. The message is delivered, but it's the wrong message, and so the wound will generally stop. That's a pibole. And it's very important, if you have a pibole where you've got these edges that have rolled under, is you've got to free them up. So there's a couple of different ways you can do it. You can surgically excise those margins. You can use a little silver nitrate to rough them up. You can be very, kind of aggressive with a little bit of mechanical debridement to kind of scrape and work those areas. We doing okay so far? Okay. We'll finish up this wound assessment piece and then probably give you like a 5-minute break so that you can empty your bladders and that kind of thing. We also want to make sure that we are documenting exudate. So we want to describe the type of exudate and the amount of exudate. That's really important because then that tells us how well the wound is doing, number one, and also if our therapy, if our wound care is appropriate. It helps us to make determinations about what kind of dressings and what kind of topical therapies to use. So we want to describe, a good way is, is there no drainage? Is there minimal? Is there moderate? Is there, is there a lot or is there copious? That's kind of a subjective thing. We understand that, but at least we want to try to ballpark it. So the amount of drainage and then the type of drainage is very important. Do we have, just a clear serous drainage that we might see in the inflammatory process? Do we have serosanguinous? Do we have, seropurulent where it's a little pink tinged, but now we see kind of some white inflammatory exudates? Do we have, purulent or creamy where we're looking at some frank pus? That's really important because, again, that's going to guide our decision making in terms of wound management. If we have a wound that has copious exudates, that's going to make us want to use a more absorbent type dressing. If the wound is not very exudating, if it's very dry, then we might want to think about something to add moisture to the wound to get the proper moisture balance. And the peri-wound area is very important because when you think about the wound, I also want you to think about you're not taking care of just the wound, but you're kind of also taking care of the skin in the area immediately around the wound. So again, do we have peri-wound? Is it indurated? Is it firm? Which means that maybe there is some underlying infection or there is perhaps some underlying tissue damage that's still evolving. Is it erythematous? Is it red and inflamed or is it, red and perhaps becoming more problematic? Is it macerated? You all are familiar with maceration? Okay, I always think of that as the pruny finger syndrome. You have a little kid or even yourself, you spend a little bit too much time in the pool or in the bathtub and you get out and you get that white pruny looking, maceration. That's what it is. It's overhydration of the tissues. Very important because if your peri-wound area is macerated, it's going to cause further damage to the wound and a lot of times the wound can start to deteriorate. Is it intact? Is it nice and clean and healthy and viable? Or is it denuded? Do we have areas where the skin is actually eroded or broken down? So that's all very, very important in terms of your descriptors. So that's kind of a very quick down and dirty on wound assessment. Any questions? All right, you're doing good. I didn't see any cases of auditorium whiplash. That's a good thing. Y'all know what that is, right? So think about wounds in terms of the fact that it's all about time. It's all about time and tissue. So as we move along, probably one of the first things to think about is wound cleansing. I think this is something that sometimes, especially as we get really busy, we tend to want to overlook. But the wound cleansing is very, very important. And when we talk about that, we have a number of different options out there for wound cleansing. What preferences do you all have? What kind of things do you have experience with or like to use or prefer?
Santil.
Well, Santil is it is a topical therapy, but what about actually just cleaning that surface of the wound?
Okay.
Saline. Saline is good. What else? All right. Again, very boisterous crowd. I can't get a word in edgewise. So saline is you know, it's kind of one of those tried and true things. You know, saline is nice. It's physiologically compatible with the body. It's usually cheap. It's easy to get. It can be a little tricky sometimes in terms of, you know, how to apply it, how to use it. You know, it has a very short shelf life. But certainly it can be a very good option if that's what you have available. Wound cleansers can be extremely helpful, and it's important to make sure you're using a wound cleanser and not a skin cleanser. They're two different animals. But wound cleansers are basically like Safe Cleanse and Sure Cleanse. There's a whole bunch of them out on the market. They're very, very nice because they have a long shelf life, and they basically have a mild detergent and a surfactant. And they come with, you know, usually a dispenser, so you can, you know, directly spray that product right onto the wound. I love wound cleansers. I think they're a great standby. I know here in the VA we don't really have too much access with them, but those of you in the community, if you have access to a wound cleanser, they're very, very helpful. Hydrogen peroxide, what do you think about that? It's kind of one of those controversial things. You know, if you have a patient that's got a really nasty, cruddy wound, or, you know, it looks like there's a lot of, you know, debris in the wound, it may not be a bad idea, you know, to use that hydrogen peroxide just to go ahead and kind of clean that wound out mechanically. There is some evidence, of course, that peroxide is very toxic to fibroblasts. And remember, those fibroblasts were those cellular players that are very important in the proliferation process. So, you know, it may not be your number one go-to, but it might be something that would be okay periodically if you really have a grungy, grimy wound. HibaCleanse. HibaCleanse is a very good product. Again, it is especially helpful if you have a patient who you have concerns about who has MRSA or who is otherwise colonized. So using a little bit of dilute HibaCleanse with some sterile water is a very, very nice option. Most important thing if you use that, however, is number one, don't get it in your eye because it can cause a little bit of ulceration. And number two, rinse it very thoroughly so you don't have any residual. Soap and water, what do you think about that? Good, bad, or ugly? So sometimes people will, for a more superficial wound, might use a little bit of soap and water. Probably not a terribly bad thing. You know, when I first started out in wound care, I used to be a real purist, and I used to say, no soap and water ever. One of the things you do have to be careful about is, you know, something as benign as, say, ivory soap is extremely alkaline. So you have to be very, very careful with, you know, just plain Jane soap and water because soap is very alkaline. A wound needs a very lovely, slightly acidic environment in which to heal. All the cellular activity that occurs in a wound occurs in a slightly acidic, moist environment. So if you're, you know, blasting this wound with some ivory soap, it's going to be a little difficult for that body to reestablish its pH. So just for a maybe superficial wound, not such a bad thing, but I would be very cautious about using it in an open, deep wound. So cleansing. So you always want to make sure you clean the wound with every dressing change. That's very, very important. Now, once you've cleaned the wound with your cleanser of choice, then you can look at what we call the time. Again, time is tissue management, and that's the T part. Tissue management is where you are basically, your goal is to try to get rid of the non-viable tissue. You want to remove the necrotic tissue and you want to promote granulation. You want to promote that proliferation. So how do we do that? We want to debride the wound. There's a number of different ways to debride the wound. I heard mention of Santil. Enzymatic debridement is a lovely option for chemically debriding the wound. Enzymatic and chemical debridement mean the same thing. That's where you have your collagenase. That's really the only, currently the only enzymatic agent we have on the market now. And what that is it's a selective proteolytic agent. So what is it? You put it in the wound and it basically liquefies the non-viable proteinaceous material. So when you put the collagenase in the wound, it is not unusual for you to start to see some increased drainage and some increased liquefaction of that necrotic tissue. That's what you want to see. That's a desired effect. So that's your enzymatic debridement. That's your collagenase. A little pearl about collagenase. If you're using collagenase, you want to be very careful not to use silver or betadine or cadexim or iodine in the wound. because heavy metals will denature your collagenase. And I know sometimes that can be a little bit tricky because a lot of times if the wound has necrotic tissue, there's a very heavy bioburden in the wound and you want to add something antimicrobial to suppress that bioburden. But if you do use that, you could use something like the hydroferro blue. It works very nicely. It's gentian violet. You'll hear more about that later, but it does not interact with the collagenase. So chemical debridement. Mechanical debridement, that can be basically, and it can be something like a wet to dry dressing, which sometimes patients don't always tolerate very well. How many of you have done wet to dry dressings on patients? So what happens when you go in to take that dressing off? It sticks, so you hate to make that wound stick, so then what do? You pour saline on it, right? And then that kind of moistens it so it's less traumatic to remove. Well, that defeats the whole purpose of the wet to dry dressing. So you could pre-medicate them, absolutely, you know, topically or you know, give them something PO. So we try to really get away from wet to dry dressings per se. Other forms of mechanical debridement would be like irrigation or pulse lavage. Those are very, very nice, very benign. They work very well. You know, a gentle mechanical scrub of the wound, especially if there's a lot of non-viable tissue, can be helpful. But that's your mechanical. What about autolytic? Can anyone give me an example of what autolytic debridement would be? Close. Santal's enzymatic. So auto means body, body self. So what would we do to promote the body's own autolytic processes? Hyperbaric has a lot of benefits. And it helps to increase perfusion to the tissues, which allows the body's own autolytic processes. But in terms of a topical therapy, something as simple as a moisture retentive dressing, your good old hydrocolloid, is an autolytic product. And what it does is it basically creates a moisture retentive environment to allow the body's own autolytic processes to occur. So any type of an occlusive moisture retentive dressing, an opsite or tegaderm, a hydrocolloid, anything that's considered an occlusive dressing would also be considered a form of... Ma'am?
What is the wound vac called?
Well, the wound vac generally is not ideally considered for debridement. It is actually more to help stimulate proliferation in a wound. So with a wound vac, and you'll hear a little more about this later, but the wound vac you really want to use in a wound that's at least 70% clean, because the purpose of that, you have to get your wound debrided before you can get that new tissue to grow. So the wound vac might be part of your repertoire once you get that wound bed a little cleaner. So if the wound is 70% clean or better, wound vac might be a very lovely option. But you've got to get the wound clean before that. And excisional is just surgical or sharp debridement. It can be done at the bedside by you know, individuals who are trained to do that, or it can be in the OR with a more aggressive form of debridement. So tissue management, you've got to get that necrotic tissue out of there. A couple of examples. This is a gentleman with a large heel ulcer, and you can see that it's kind of open, it's been draining. You've got this necrotic soft eschar here. Let me ask you something. If you were looking at this patient and you saw this eschar and it was dry and firm and hard, would you debride it? How many would debride it? How many would not debride it? Fantastic. Yes, if the exception to moist wound healing is if you have dry, stable eschar on a foot, particularly on the heel, especially in a patient who you know is maybe compromised in terms of their circulation, you want to leave it dry and intact. However, if you get something that is open and draining, again, if it ain't red, it's dead, and it's got to come out of the wound. So we've got to get that debrided. And here's an example of, again, a heel ulcer that was a combination of enzymatic debridement along with sharp debridement to get that non-viable tissue out of the wound. So time, T is time is tissue. So one of the important principles of wound care is we want to try to get that tissue to the point where it's clean. We want to get the necrotic tissue out. We want to promote that healthy new granulation tissue. We want to get proliferation going. The next phase of wound management is I, which stands for infection. Now let me ask you this. Can a wound heal if it has bacteria in it? How many think yes? Okay, a few brave souls. How many think no? Okay, a few brave souls. You are Just not an adventurous crowd this morning. I think you need more caffeine. All right. Typically, if, anytime you have an open wound, after just a few hours, that open wound is going to become colonized because we have bacteria that thrive in our bodies, they live with us, they work with us, and most of the time, they don't pose too much of a problem. When a bacteria gets into a wound, we say that that wound is contaminated. It means it has bacteria in the wound. If the wound, if that bacteria then starts to grow and reproduce, we say then that that wound is colonized. It means that there are bacteria that are actively growing in the wound. And contaminated and colonized wounds can still heal for the most part. However, when we start to get either so many bacteria or we get very pathogenic bacteria that actually interfere with the wound healing process, and we see signs and symptoms of infection, then that's where we really start to become very, very worried. So just in terms of infection, as I mentioned, contamination, you have microbes present. Wounds can still heal if they're contaminated or colonized. But if we have infection, we truly have the infection of tissue. And the textbook definition is more than 10 to the 6th power of tissue per gram of, more than 10 to the 6th organisms per gram in tissue. And typically when you have a wound that is infected, you will start to see many of your different signs and symptoms of infection. So when we think about it, it's sort of a continuum. It's really not a black and white issue. It's really a continuum. So we have sterile, which is what we have in the OR. Open wounds, again, contaminated, colonized. Critical colonization means that we've got just a huge amount of bacteria in the wound, and the wound is maybe not necessarily infected, but it's just kind of come to a screeching halt in terms of wound healing. We say that those wounds are critically colonized, and it's the critically colonized and the infected wounds that really need a little bit more active intervention. Your critically colonized wounds really respond well with usually some debridement and a topical antimicrobial therapy, either a silver product, a cadexamer product, even sometimes some of your more acertic agents such as an acetic acid or Dakin's short term. And then infection, of course, typically will need usually local care and then often some type of a systematic treatment with antibiotics. So what are your classic clinical signs and symptoms of infection? You all know these and you've seen these. Your erythema, there's redness around that area. We have induration, you palpate it, it's very firm, it's very hard. The tissue doesn't have that same resilience that it does in other parts of the body. It's not supple. You have pain, and that's always a big red flag. Pain is something that may be common in a lot of wounds, particularly if they have ischemic wounds or vascular wounds, not so much in diabetic wounds, but there can be exceptions to that. Pressure ulcers. But what you really want to be assessing for as part of your assessment, looking at pain, do we also have a situation where now, it might have been a little tender before, but is there sudden pain? Is there all of a sudden, there's a lot more pain than there used to be? That may be a big red flag. And especially if it's in a patient who has known loss of protective sensation, if they're neuropathic and now all of a sudden they've got pain, that's a big red flag that you want to pay attention to. Purulent drainage, again, can be a telltale sign. Changes in color, if the wound goes from being a nice, healthy, viable, beefy red that we talked about to kind of purple or dusky or gelatinous or friable, we would get concerned about that. And of course, sudden changes in odor. That's where odor is kind of a relatively important thing because, typically some wounds will have odor and not be infected, especially if it's a necrotic wound that's liquefying. You're going to have a little bit of odor with the liquefaction of that necrotic tissue. So the odor is something that I think, as you do more wound care and you get more involved in, you can kind of tell with your nose over time whether this is an expected odor or if this is something that may be a clue that you might want to pay a little more attention to. So again, as part of your assessment, think about odor as well. And then in chronic wounds, again, you may not always have some of these very classic signs and symptoms of infection. If you have a patient who is on immunosuppressants or who is on steroids, they may not get that classic erythema that you see. So other things that you also want to consider is, you're doing all the proper wound care. You're doing great wound care, but all of a sudden the wound is just not healing anymore. It's stopped. We've kind of hit a plateau. We're not doing anything. Discoloration or duskiness to the wound bed, that could be an indication that you've got a perfusion issue, but it could also be some infection. If the tissue becomes very friable, I've never heard of garnulation tissue before. That could be a new term we can invent. Friable granulation, it bleeds easy or it's gelatinous. You know, you go to clean it and it just seems real oozy and weepy and it just is very unhealthy looking. As I mentioned, unexpected pain or tenderness or a sudden increase in wound drainage, those to me are big red flags that I would want to investigate further in terms of infection. So, how do we treat them? There's a lot of debate about culturing. Should we culture? Should we not culture? What do you all think? All right, some say yes, some say no. It's kind of a loaded question because it is debatable. You know, generally speaking, you know, years ago we had a wound that was open and we had concerns about infection. We would do a swab specimen, you know, where you basically take a swab and you know, do the correct way is to do the Levine method for swab, where you rinse the wound with saline and then you take a sterile Q-tip applicator over the cleanest part of the wound over about a 1 centimeter area, and you press and you kind of roll at the same time to lift cells off the surface. That, you know, that is still done, but it's debatable because even with ideal techniques, it may not really give you the most reliable results. Remember, we talked about a lot of these wounds are already contaminated or colonized, so a lot of times you may only be getting, you know, a colonized or contaminated specimen, and you really want to make sure you're treating a true wound infection. So it's a debatable thing for you to be aware of. How do we culture? You know, ideally, the gold standard is really to do, you know, either an aspiration or actually a deep tissue culture or biopsy. That's really the gold standard because that's where you're actually excising a true sample of tissue, and if that is really infected, that's going to give you the most accurate indication of what's going on with the wound. I remember when I was a brand new nurse, you know, just in my very first position, and I was working in a surgical unit, and you know, I remember my first experience in getting a wound culture. I thought, okay, great, I'm going to go get a wound culture. So I grabbed my curette and I walked over to the patient's wound and I whipped off the dressing, and I, you know, looked for the gooeyest, nastiest, grossest part of the wound that I could possibly find, and I'd stick the Q-tip in there and pulled up a nice big glop of something. I know you probably have done this too, but don't want to admit it. And I thought, that is a great specimen. That's going to grow some great stuff. Well, as I mentioned, that's exactly what you don't want to do. You know, the idea of if you do get an order for doing a swab culture, just make sure that you do it correctly if that is part of your policy and procedure. But ideally, the best way to do a culture is really to do like a deep tissue excision or aspiration. So when do we initiate antibiotics? Again, there's debate about this as well. You know, a lot of times we will treat, if we do have a lot of these indications of infection, we may treat that wound empirically with a broad spectrum antibiotic. If you do strongly suspect infection and you get an accurate tissue sample, then at that point you would want to treat based on the sensitivity results for that particular agent or agents that you have. So I think just be aware that it is kind of one of those, there's some two sides of the fence on this particular issue. Any thoughts on that? Any other experiences? Okay. All right, well, let's move on. So we've talked about time, the T and the I. Let's talk about M. M is moisture balance. So again, when you're managing a wound, you want to make sure it's kind of like Goldilocks. You don't want too much moisture, but you don't want too little. You want just the right amount of moisture. And again, that's very, very problematic. So in terms of exudates, a good way to think about it is if it's moist, add something to dry it. If it's dry, add something to moisten it. And the other thing, as I had talked about before when we discussed tunneling and undermining, if you've got dead space, fill it, but don't cram it. It's not an exercise. Again, I remember as a brand new novice nurse, I always thought that the more Kerlix I could pack into that deep abdominal cavity, the better it was. You know, and we were taught, you know, get a really nice tight packing in there, and that's exactly what you don't want to do. The idea about filling the dead space is a moist dressing in contact with all dimensions of the wound. Because again, these wounds are big, they're three-dimensional. You want to make sure that you've got dressing in contact with all surfaces. But if you cram that dressing in there, then it's really going to thwart the wound healing process. So again, it's being very careful and being very cautious. This is a gentleman who you can see has a open full thickness ulcer here. And again, just another example of this is that maceration. This is that, increased exudate. It's pouring over onto the surfaces of the wound. And as you can see, the tissue is becoming overhydrated. And that makes it very susceptible to sloughing off and causing more damage and actually increasing the size of the wound. So the moisture balance is extremely important. So just some basic examples for the dry wounds. Again, if you want to donate moisture to the wound, your hydrogels are a perfect option. Your kerosene gel, your safe gel, your new gel, your Instacyte gel, any of those are absolutely appropriate if the wound is dry and you want to maintain a moist environment. Foams can be very nice. Foams can kind of work for you in a number of ways because foams kind of help with managing moisture balance, and they're good for minimal to moderate exudates. Some foams are thin, some are thick, some are impregnated with antimicrobial agents, some are impregnated with surfactants. The Hydrophera Blue, you've heard me mention, is a very nice product that's impregnated with gentian violet, so it's a very good antimicrobial option. Again, if the wound is dry and you have eschar in the wound, you can also keep it nice and dry and tainted with betadine. Again, that's that exception to moist healing. You have that dry necrotic gangrene or dry eschar on a wound. You really want to try to keep that dry if you have a compromised host until you can gather more information about their circulation and so forth. Your wet wounds, a couple of your options would be the calcium alginates. Those are very good for moderate to large amounts of exudate. They also can be very useful in helping to fill the dead space. And then your hydrofibers, which I absolutely love, that's your Aquacel. And that is basically, both of these, the calcium alginate is a sort of a seaweed-based derivative, and the hydrofiber is a plant-based derivative. But the hydrofiber, in my experiences, is probably a little bit more absorbent than the calcium alginate. And it can be impregnated with silver. Both of these can, which can be very nice if you have a heavily colonized or critically colonized or infected wound, can be very useful. So again, if it's dry, add moisture. If it's wet, try to dry it up. Moisture balance is really, really important. If the wound is getting too wet, you want to think about, do you need to increase the frequency of your dressing changes or do you need to change your topical therapy? If the wound is too dry, you need to make sure it's not getting dried out. Your wet to dry dressings, again, I'm not a big fan of. And you will have, some providers that maybe don't do a lot of wound care will tell you to do a wet to dry dressing on a wound, especially if you have like an open surgical wound or an open clean wound. What you may want to try to think about in terms of a paradigm shift is not really think of it as a wet to dry, but as a moist to damp. So, saline packed gauze put into a wound will keep that wound bed moist, and that's appropriate. You just don't want to let it dry out because then you have traumatic removal, it's painful, not really the best way to debride a wound. Any questions about moisture balance? Okay. So edges. Edges are very important because, again, when we talk about that second phase of wound healing where you have the proliferation of the tissue and then you want those keratinocytes, those epithelial cells to migrate across the wound, well, they can't do that if the edges are not healthy. So we have to look at different ways to help promote those edges. And this is probably one of those areas that we don't always think about so much with the principles of wound care. Again, if we have the epibole in the wound, we've got to get those rolled edges loosened up. We've got to get those excised or debrided. We want to do what we can to promote epithelialization. Again, we want to do what we can to have a nice clean surface to promote the floating or the migration of those cells. So some of the options that we have, and again, wounds don't necessarily have to have all of these to heal, but these are certainly some very lovely options that, if you have in your arsenal can be very, very useful. Your collagens. Your collagens come in a variety of forms and shapes and sizes. They come in granules, they come in sheets. The product Oasis, the product Endoderm are very, very nice collagen products. They're acellular matrices that kind of provide a framework or a stratus, if you would, for tissue to migrate across and also to encourage epithelialization. Collagens you want to use in wounds that are basically clean. Don't use a collagen in the wound if it's necrotic. Again, if the tissue's got non-viable tissue in it, the wound has non-viable tissue in it, you have to really get that out of there before you get to any of these more advanced types of therapies. So you've got to get that wound clean. Your negative pressure wound therapy, your wound vac, is a lovely option for both promoting granulation and also helping to contract the wound and helping to promote epithelialization. Again, caveat with the wound vac, you want to make sure that you're using it on a wound that's at least 70% clean. You want to use it with a little caution if the patient has active osteomyelitis, unless it's being treated or it's been surgically addressed. Or if there's any known cancer in that site, you want to be a little careful. And then your dermal skin substitutes. There's a variety of them on the market. I know here within the VA we've had the opportunity to be able to use the Dermagraft, which is primarily neonatal fibroblasts, a very, very rich form of growth factors that is wonderful for helping to promote healing and epithelialization. We also have Apligraf, which is more of a bilayered type of bioengineered skin substitute. Also comes from neonatal foreskins, in case those of you sitting in here were not aware of that. It's kind of an interesting little piece of trivia you could share over a glass of wine or something. But it's bilayered, so you have basically, again, a sheet of dermis, and then you have epidermal seeds on top. Both of them are very good. I've used both of them and have had very positive experiences with them. And they're just a really nice opportunity to try to get that wound that's kind of slowly moving along to just kind of push it forward for healing.
Do you use Prisma with that also?
Yes, Prisma is another very nice option. Prisma, Promogran are also very, very nice opportunities. The Prisma and the Promogran are basically, the Promogran in and of itself is an oxidized cellulose and has a collagen base to it. And the idea behind using the Prisma and the collagen is that in chronic wounds, one theory as to why some wounds will not heal is that there's an imbalance in enzymes. There's an imbalance of what they call matrix metalloproteases, or MMPs. So the idea behind using something like the Prisma or the collagen is it binds some of those MMPs. And the MMPs, if there are too many of them, will continue to degrade and break down the wound and make it difficult for it to heal. So using something like the Prisma or the Promogram, which we also have here in the VA, will kind of help bind those MMPs and help with healing. So yes, that's another option. Thank you for mentioning that. The Prisma has got the silver in it as opposed to the Promogram, which does not. Yes, sir?
I'm also using stem cells using high mobile.
Would you mind standing up and speaking a little bit more to that? Because it's another nice option that we have here available in the VA for stimulating wound healing.
It's a Osiris, it's a kind
It's a really nice product because it is it's immunologically inert, so you won't have to worry about rejection issues like you would with other types of transplants, so to speak, and provides a rich form of exogenous growth factors to help with healing. And I know podiatry is using it very actively and has had some phenomenal results with their patients. So it is nice to know that we have that as another kind of another tool up our sleeve, so to speak. Absolutely. All right. And we had talked about that epibole before. Again, those rolled edges, they have to be excised, they have to be removed in order to allow the body to continue forth with its healing process. So what are some factors that affect healing? We've kind of alluded to a lot of them if we've gone along, but what kind of things, and you feel free to shout them out, what kind of things do you think are going to directly impair the ability of a wound to heal?
Nutrition.
Nutrition. What else? Hydration. Yes, a patient who's dehydrated is going to be very impaired, absolutely. So nutrition, hydration, that's moisture balance for the body. What else? Infection, circulation, good. Activity, diabetes, yes indeed, absolutely. Any other offload? Yes, absolutely. Pressure reduction, pressure relief. And when we talk about offloading for the patient who has the lower extremity wound, the offloading is absolutely critical because you can have the best care in the world, but if that patient continues to put pressure on that foot, the wound is just not going to heal. You're fighting a losing battle. That's extremely important, especially with patients who have diabetic neuropathic ulcers, primarily on the plantar surface, but in the foot in general. For patients who have pressure ulcers, they have to be on appropriate pressure redistribution surface so that they don't have, so they get offloaded as well. So those are all extremely important things. Infection we've talked about. Again, we really want to try to identify infection early when we can and intervene appropriately. And that would include, again, appropriate topical management as well as systematic treatment of the host if we know that the wound truly is infected. Nutrition. You're going to get a very good talk tomorrow morning on nutrition, those of you who attend. But nutrition is absolutely critical, and I think sometimes we don't always appreciate the importance of it, but wounds are much more, there's a higher incidence of wound development in patients who are chronically undernourished, especially pressure ulcers. If the patient is not eating, they're at much higher risk for the development of breakdown. And by the same token, if you have someone who has an open wound and they are not eating, if they are not getting adequate hydration, if they're not getting adequate calories, protein, fats, everything, they are not going to heal. So nutrition is really, really important. And ideally, you know, unless the patient has a lot of concurrent renal issues, you really want to get, you know, anywhere from 1.2 to 1.5 grams of protein per kilogram of body weight per day is ideal for helping, again, because remember we talked about proliferation and we talked about the body, you know, the fibroblasts laying down that collagen. Well, collagen's protein. You know, you can't make it if you don't have it. You've got to have the raw ingredients, so the nutrition is extremely important. So you want to make sure you have adequate protein. You want to make sure that you have adequate hydration to the wound as well. Patients who are dehydrated are at much higher risk for the development of renal issues and sepsis and all kinds of problems. And it makes it really difficult for that wound to heal. The other thing, just as a little bit of a side note, what do you think about supplements? Do you think patients should be on supplements for healing?
If they're not eating.
Okay, all right, good. What do you think about like zinc or vitamin, multivitamins or C? What are your thoughts on that?
Yes, not protein.
Okay, so protein, if the patient's not getting enough protein in their diet, we can also add protein in the form of different protein supplements. There's some really good ones out there. There's Prostat, there's, you know, Benapro, Promod. There's a whole number of different ones out there. There's Juven, which is a great product. We use that here on some selected patients. Hydration is important. Getting adequate number of total calories is important. And then the idea of supplements or multivitamins is kind of one of those things that has been sort of debated somewhat hotly. It's probably never a bad idea to put somebody on a multivitamin. You know, it really isn't going to hurt anything. A lot of people think about multivitamins as being a way to make your urine very expensive because your body will take what it needs and get rid of the rest. But I think it's not a bad idea. It's kind of like insurance. It's there if you need it, and if you don't, that's fine. You get rid of it. Now, zinc, on the other hand, you know, is considered to be a coenzyme in a lot of different processes for wound healing. And there's been a lot of debate about, you know, zinc yes, zinc no, how much, how long. And probably there's not really a lot of good confirmation on this, and you'll hear more about this tomorrow. But general rule of thumb, you know, is that zinc is probably not a bad idea short term, because most of your older adults are zinc deprived. You know, we get a lot of zinc from things like, you know, meats and seafood and shellfish and things like that, which a lot of our older adults don't usually have access to necessarily. But a lot of older adults are zinc deprived to begin with, so it wouldn't be a bad idea perhaps to give them some zinc short term. Why not long term? Well, there's some evidence that suggests that long-term supplementation with zinc can actually cause other types of problems, that zinc can compete with copper, and it can cause a secondary copper deficiency, which can result in an anemia for the patient. The other thing you have to be careful about with zinc is that it sometimes it can cause a little GI distress for some patients. So you just want to be aware of that. So general rule of thumb, you know, with my patients is I'll do like 2 weeks of zinc, you know, 220 milligrams daily times, you know, 14, 15 days, and, you know, kind of leave it at that. If the wound is going on for a period of time, I may add it back in for a short period of time. But that's kind of the debate on zinc. Vitamin C is, you know, thought to be helpful certainly because it can help with the collagen cross-linkage in wound healing, and can just be very helpful as another supplement. Plus, it's an antioxidant as well. Not a lot of strong evidence about that, but again, it's one of those things that probably isn't going to hurt. I'll get off the nutrition soapbox. Pressure, friction, and shear. Again, we need to really try to manage pressure, friction, and shear. If the patient has a mobility issue, they've got to be, you know, the affected area has to be offloaded. So again, your pressure redistribution surfaces are really important. Managing your friction and shear are going to be very important, and Sri will talk a little bit more about that. If the patient is ambulatory and they have a plantar ulcer, an ulcer on their foot, they have to be in the right type of offloading device that will help with managing that. You're going to hear a little bit more about diabetic foot ulcers tomorrow, I believe, and you'll get a little bit more detail on that. But we also have a couple of really good resources in the back in our podiatry department that can also maybe speak to you about that if you have other specific questions during the break. Putting you on the spot here. And perfusion and oxygenation, absolutely. You know, if you ain't got no blood flow down there, it isn't going to heal. So you have to really do everything you can to maximize your perfusion and oxygenation. And that's probably especially important on lower extremity wounds. You know, if you have a patient who has a non-healing wound, you know, what is their circulatory status? And that's where, you know, things like your non-invasive vascular studies can be very, very helpful to determine what their circulation is. And we'll talk a little bit more about that later. And then oxygenation, are they being well oxygenated? And this is a situation too where, as an adjunct therapy, the hyperbaric can be a wonderful way to help augment oxygen, and that's available either through systemic oxygenation in a chamber or through like more of a local topical application as well. So you want to do what you can to perfuse and oxygenate. In some cases, you know, patients may also require some type of a surgical intervention in the way of a bypass to restore perfusion to their tissues. And of course, as you all know, diabetics. And we have no diabetics in our population, right?
Right.
It's almost like who's not diabetic. Yeah, unfortunately, that is it's a problem that's epidemic. And the big problem that I think a lot of us face is not only do we have diabetics, but we have a lot of diabetics that are extremely difficult to control for various reasons. And that becomes a huge challenge. But again, you know, poor glycemic control, you know, there's something called hyperglycemic-induced leukocyte dysfunction. So you've got, you know, sugars that are out of control. It directly affects the ability of your white cells to do what they need to do in the body to protect it in terms of inflammation and mounting a defense against infection. That's one reason, not the only reason, but one reason why diabetics are so prone to infection is they just cannot mount that type of a defense. Again, when we talked about wound healing 101, I keep going back to it, but it is important. Again, those macrophages, those neutrophils, very, very important players for the body in terms of defending itself. Well, if you have somebody who's got really bad leukocyte dysfunction, those things aren't going to work as well. They're going to be kind of like, you know, a bunch of, you know, impaired, you know, cells that just can't do the right job. So you have to make sure that the glycemic control is being managed. And the moisture and incontinence. You know, one of the other issues that we have with a lot of our patients is not just that we get a lot of exudate in the wounds that will kind of flow out onto the wound and break down the skin, but we also get what's called incontinence-associated dermatitis. And again, you don't have any patients that are incontinent, right?
You wish.
Yeah, that's not an issue. But yeah, patients that are incontinent of urine and/or feces, again, are very prone to developing skin breakdowns that can develop into further wounds and ulcers and lesions. So managing the moisture and incontinence is extremely critical. Stress. Would you think that would be a problem? Yeah, there's some really interesting research that actually came out of the dental world in terms of really looking at a direct effect between stress and wound healing. And what's very interesting is if you think about it, when we're under stress, whether it's physiological stress or psychological stress, what happens? What do?
You don't eat right.
Exactly.
You don't sleep right.
Exactly. All of that happens. And the other thing our body is doing is we're kind of going through this chronic fight or flight syndrome. And our bodies are also stimulating, it's called the HPAC axis, the hypothalamic pituitary adrenocorticotropic axis. Say that one 10 times fast.
Cortisol.
The HPAC axis, our body's producing all this cortisol. Well, what is cortisol? It's a natural steroid. And what do steroids do in the body? Yeah, they can cause edema, but they can suppress the inflammatory response. They can delay wound healing. And that's what happens when we're under a lot of stress. We don't heal as well. Anything else you can think of? What else could possibly affect the ability of a wound to heal?
Medications.
Yes, medications, absolutely. So medications, so if a patient is on immunosuppressants, would be a good example. That would be potentially a factor. If they're on anti-cancer drugs, anti-inflammatory drugs, absolutely. Other thoughts, other ideas? Smoking, thank you very much. That should have been up on there. I'll have to add that next time. Absolutely, yes, smoking is the bane of our existence because smoking affects the immune response, but it also really accelerates the development of peripheral vascular disease. You know, it really, really trashes our macrovascular system and again affects our perfusion directly. There's like I think there's a correlation of like 80 to 90% of patients who have significant PAD were smokers or tobacco users of some form. What else?
You know, Diane, I would think poorly educated nurses. You know,
Well, knowledge on the part of the patient, knowledge on the part of the providers, absolutely. Knowledge is power, and we need that power to be able to render good care to our patients. Absolutely critical. Other thoughts about things that can affect wound healing? Ma'am?
Sometimes your environment also. If the patient does not have air conditioning and they're in a facility, they're not going to heal.
Excellent. Socioeconomic factors and environment. Absolutely. If you don't have the money to get that, Bactroban from the pharmacy, well, it's not going to go on there and the wound isn't going to heal. Or, yeah, you have a poor living environment, unsanitary conditions, or you don't have a good environment to live in, you don't have support, you don't have somebody to help you, take care of that wound on the bottom of your foot because you can't reach it yourself. Yes, absolutely. So, really looking at the psychosocial is absolutely critical. I'm glad you brought that up because I think that is an absolutely essential point that sometimes we don't think about because we tend to look at the wound and we're like, okay, what do I got to do to take care of this wound? And sometimes we don't think about the person, and then also what's outside the person in their external environment. Thank you. Pain, again, is very, very important. It's sometimes called the fifth vital sign, and it's something that we want to look at on a regular basis. If we need to pre-medicate them before we do the dressing change, that's fine. If we need to think about a topical anesthetic, that can be very, very helpful. And again, as I mentioned previously, if there's a sudden increase in pain, that's a red flag that something's going on. So we want to always make sure we investigate that. So that was a whole lot in 2 hours, and you all have done, I'm really impressed. I really didn't see too many eyes at half-mast, so that was really good. So I was either loud enough or you were awake enough or maybe a little bit of both. So with that in mind, I have a joke for you, if that's okay, and then I'll let you, I think we have a break until, where's Sue? I was going to see until 10:15. 10:15, okay. Well, we have a couple minutes. All right, so there's a group of surgeons in there. Some of you might have heard this joke before, so don't give it away if you do. There's a group of surgeons, and they are taking a break in between cases in the OR, just kind of hanging out, just relaxing a little bit, taking it easy for a few minutes in between the next cases that they have. And they just get to, shooting the fat, and they start talking about the different kinds of patients that they like to work on. And the first surgeon says, well, you know, I really, really like to work on librarians because when I go in there, I find that everything is just in completely beautiful alphabetic order and very, very neatly organized, and I can find everything that I need to, and it's just such a pleasure to work on these folks. And the second surgeon says, well, I really like to work on accountants, you know, CPAs in particular, because I go in there and I see that, you know, everything is in beautiful numeric order and, you know, everything really adds up when I'm doing my thing in there. It's just perfect. I love it. And the third one says, well, I kind of like to work on electricians because, you know, when I go in there, I can match red to red and black to black, and I always know where the ground wire is, and I never get shorted out or surprised. I'm never shocked by what I see when I go in there. And the fourth one says, well, I like to work on mechanics because when I go in there, I can, you know, kind of do my thing and I can be really creative. And, you know, generally if I have a part or two left over, they don't really mind that much. And the last surgeon says, well, I really like to work on lawyers. And the others are like, what? Why in the world would you want to work on lawyers? I always love lawyer jokes, by the way. And the surgeon says, well, you know, I like to work on lawyers because it's simple if you think about it. I open them up, I find they have no heart, no guts, no spine, and both ends are interchangeable. So, thank you very much. I think that'll give you a little time for
Have given you all of my heart, but there's someone who has torn it apart, and she's taken just all that I had. If you wanna try to love again,